Good evening, everyone. Welcome you all for the IPNA endorsed Webmaster Series 2021. It is a special series only on Pediatric Glomerular Disease Symposium. And it will be extending from May 22nd to July 14th on every Wednesday and Saturday with a standard time of 18:30 to 20:30. Now I welcome Dr. Kannan, our Medical Director, to give the welcome address.
Good evening, everybody. It is a matter of immense pride that Dr. Mehta Hospital is organizing this prestigious IPNA endorsed Webmaster Series 2021. This program is organized jointly by the Department of Pediatric Nephrology and Department of Pediatrics, Dr. Mehta Multi-Speciality Hospital, India. Dr. Mehta's hospital is an heritage hospital of 85-year-old lineage and has a mighty presence in the field of pediatrics and allied subspecialties for the past 2 decades, rendering human service to children at large. It is my pleasant duty to welcome the dignitaries, and who is more suitable to be welcomed than our old Professor Dr. Nammalwar, the father figure of pediatric nephrology in this part of India, the pioneer nephrologist, pediatric nephrologist, was instrumental in starting this department in Dr. Mehta's hospital, who along with Dr. R. Sundaram and Dr. L. Subramaniam, the Trinity, as we fondly called, established the Department of Pediatrics and Allied Subspecialties in Dr. Mehta's hospital. My humble pranams to Professor Dr. Nammalwar. I welcome you, sir. I welcome you and I salute you. I welcome to this. He, along with our late Dr. M. J. Kumar, MEK as he is fondly called, who is unfortunately no longer physically with us, and who I am sure his soul will be loitering somewhere here among our midst, bless us in our endeavors. I welcome Professor Dr. Vijay Kumar, though he is not physically with us. It is my pleasant duty to welcome Dr. Thangavelu, the teacher of teachers, nationally renowned general pediatrician, and fondly liked by all of us, his colleagues, and also by his immensely liked by his students. I welcome Professor Thangavelu. I welcome the ISPN team, Dr. O.P. Mishra, former Dean, Institute of Medical Sciences, Banaras Hindu University, Professor in charge, Pediatric Nephrology, President, Indian Society of Pediatric Nephrology. I welcome you, sir. I welcome Dr. Anil Vasudevan, Secretary, Indian Society of Pediatric Nephrology, Professor and Head, Department of Pediatric Nephrology, St. John's Medical College. Our brothers, the IAP team, Tamil TNSC, Dr. Ismail, Dr. K. Rajendran, and Dr. Gopal Subramaniam, we welcome you, sir. And our close colleagues, the IAP team of Chennai City branch, Dr. Venkatesh, Dr. Sudhakar, and Dr. Karamat. The IAP CCB and IAP TNBC has been collaborating with us in all our endeavors. We thank you, we welcome you both, sir. We welcome Dr. Edwin Ferrando, Professor of Nephrology, Dr. Mehta Hospital, but who has rendered valuable support to us. Professor Dr. M.C. Gaurishankar, one of the pillars of our hospital, we welcome you, sir. We welcome Dr. Saravana Kumar, our unit head. And I welcome Mr. Sameer Mehta and Dr. Pranam Mehta. Mr. Sameer Mehta is our Vice President, Dr. Pranam Mehta is our Director. They have been encouraging us in all our ideas. They have been giving active support to us in all our academic programs. So I welcome both of you, sir. And as the Upanishad says, let noble thoughts come to you from every side. Knowledge and wisdom come to you from every side. Let the knowledge we get from this webinar series help us in serving the children. Thank you very much. I now welcome Professor Dr. Thangavelu to give a brief introduction about Dr. Nammalwar. Over to Dr. Thangavelu.
Thank you, sir. I'm very happy to welcome my teacher and mentor, not only for me, for many of our pediatricians and nephrologists. Professor B.R. Nammalwar, Senior Pediatric Nephrologist and former Professor of Pediatric Nephrology, Institute of Child Health and Madras Medical College. He is the first pediatric nephrologist of this part of the country. Dr. B.R. is considered a founding father of pediatric nephrology through his characteristic combination of academic excellence, mentorship, and love for students. He has inspired generations of pediatricians to provide service to children with kidney diseases. Indian Society of Pediatric Nephrology presented Lifetime Achievement Award to Dr. B.R. Nammalwar for his outstanding contribution to the care of children with kidney diseases. After his retirement from Madras Medical College, he established pediatric nephrology centers in Kanchi Kamadi Children's Hospital and also in Mehta Multi-Speciality Hospital, along with his colleague, Professor M. Vijay Kumar, late Professor M. Vijay Kumar. Apart from providing clinical services, the BRN is an educator par excellence. He is known for his remarkable teaching skills among pediatricians and adult nephrologists alike. In addition, he also founded the fellowship courses in Mehta Multi-Speciality Hospital as well as in Kanchi Kamadi Children's Hospital. That BRN founded the Kids Kidney Care Trust to spread awareness of pediatric nephrology among community physicians. He received multiple awards for teaching by parent institutions, state level and national level, such as MGR Medical University, the IAP, and IMA. His textbook, The Principles and Practice of Pediatric Nephrology, written entirely by pediatric nephrologists in India, is a key reference manual for pediatricians as well as pediatric nephrologists. He has also published many scientific articles in national and international journals and has been invited to deliver numerous prestigious orations. He is also an emeritus editor of the popular journal, Indian Journal of Pediatrics. Over to Professor B.R. Nammalwar.
Thank you. Thank you, Dr. Thangavelu and Dr. Kalevani for this wonderful opportunity. I'm very, very happy to meet all my family members. And I think it's a special thanks to Dr. Kalevani for having the organization. Before I must congratulate Dr. Kalevani for this wonderful organization on the Symposium on Glomerular disease in children. He has begun what you call from the alpha and the omega of glomerular disease in children. He's beginning from the A to B, A to Z. And there's a galaxy of teachers from India and abroad who are guest speakers. It's really wonderful how a single person could do so much. I congratulate you and wish you and the symposium grand success, and I'm sure it will be a grand success. God bless you.
Yes. Thangavelu sir, can you proceed with introducing the other speakers?
Respected dignitaries, Professor B.R. Nammalwar, Dr. Kannan, Dr. Edwin Fernando, Dr. Saravana Kumar, Dr. Rupesh Reena, representative of IPNA, ISPN team, Dr. O.P. Mishra, today's expert speaker, Dr. Anil Vasudevan, my dear friends and IAP functionaries, Dr. Ismail, Dr. Rajendran, Dr. Gopal Subramaniam, Dr. Venkatesh, and Dr. Sudhagar and Dr. Karamat, and my colleagues from Mehta Multi-Speciality Hospitals, Professor K. Nedinjalian, Professor N.C. Gauri Shankar, Professor A. Vijay Raghavan, and Professor L.K. Prem Kumar. I welcome you all for this Webmaster Series. Our dear Chairman, Mr. Dilip Mehta, Vice Chairman, Mr. Samir Mehta, Director, Dr. Pranav Mehta, and thank you all for your active encouragement and cooperation for all the academic activities. At this point, I have to tell something about the Webmaster 2020, which happened in the last year. This Webmaster 2020, 21 is the continuation of webinar series conducted successfully in the year 2020 during the heights of pandemic, that is between September to December, which was organized by Department of Pediatrics and Pediatric Nephrology of Dr. Mehta's Hospital. 2020 Webmaster Series had an excellent reach across the globe. It had reached almost 107 countries, 540 cities, and individual hospital count of 1,101. This 3.5 months of journey was a wonderful journey. It was a new learning experience for the Department of Pediatrics and Pediatric Nephrology, personally as well as professionally. It makes us feel that pediatric nephrology in Mehta Multi-Speciality Hospital was redefined and taken a good shape to fly high. This program of 2021 came out as a great teaching module. So we continued this module into the year 2021 as Webmaster Series 2021. Once again, I'd like to thank the administration for providing active support and encouragement to conduct these academic programs. This 2021 series, the current series, is sponsored by the International Pediatric Nephrology Association, IPNA, and is hosted in association with the Indian Society of Pediatric Nephrology and the Indian Academy of Pediatrics. IPNA is known for promoting academics related to nephrology. It's a platform for spreading pediatric nephrology knowledge across the globe. Many thanks to IPNA. The academic content of this 2021 series is focused on pediatric glomerular disorders, as already mentioned by Dr. Kalivani, our pediatric nephrologist, who is the organizer for the whole program. Modern medical knowledge is rapidly growing compared to that of expansion of the universe after the Big Bang events. So much rapid expansion. So a general pediatrician cannot cope up with this expansion. He needs to know the recent developments in various aspects of nephrology. The series have been organized with that objective and hope it will satisfy the academic needs of the medical community. In this series this year, totally 38 lectures in 16 webinar sessions. 16 webinar sessions containing 38 lectures have been planned to be delivered by national and international speakers and world authorities on these themes. Topics have been chosen in such a way that it covers common areas like nephritic syndrome, because the organizer has to balance on one side the common illnesses which will satisfy the pediatricians and core nephrology for the nephrologist. It is nicely balanced so that the common topic like nephritic syndrome, nephrotic syndrome, and hypertension for the benefit of general pediatrician, pediatric postgraduates. At the same time, core nephrology topics like dialysis, renal transplantation have been selected to cater the interest of nephrologists and postgraduate trainees in nephrology. All talks are delivered by masters in this field. To take an example, Professor Joseph Flynn, who has charted all the guidelines on hypertension, is delivering a lecture on the last topic in the series. He's endowed chair in pediatric nephrology, editor-in-chief of Pediatric Nephrology Journal, Pediatric Nephrology Chief, Division of Nephrology, Seattle Children's Hospital, USA. Next, Dr. Mini Sarwal, who is a leader in UC San Francisco program. UC San Francisco, that is UCSF program of pancreas kidney transplant program. She's an Indian who also owns a lab in her name, a Sarwal lab. Next faculty is Dr. Rupesh Raina. He's an adult and pediatric kidney disease hypertension specialist at Akron Children's Hospital and Akron General Medical Center at Cleveland Clinical Foundation. Our national faculty, Dr. Arvind Baga, who is the person representing the whole pediatric nephrology community from India. So this webmaster series got a lot of faculty who are rich in their knowledge to deliver their talk to the benefit of both pediatricians, pediatric nephrologists, and residents and postgraduates in both the departments. This series of talks are arranged twice a week on Wednesdays and Saturday evenings in a time span comfortable for majority of the participants across the world, because the listeners are spread out all over the world. So this is a time that maximum number of coverage for all the viewers. That is why this time has been chosen. Thank you very much, Dr. Kalivani, for this opportunity. I hand over the responsibility to Dr. Gauri Shankar.
Good evening all, good morning all, good afternoon all. I need to welcome people from all over the globe. First, probably it is a vision of the teacher of teachers, Dr. B.R. Namalwar, who is the Director of Medical Studies as well as the Director of Pediatric Nephrology of Dr. Mehta's, to give whatever he had learned during his tenure as a pediatric nephrologist, both in government and private. His main aim is to educate young doctors in the field of pediatric nephrology. With that vision, he started the department, and he was able to get success with able support from late Dr. M. Vijay Kumar and the pediatric nephrology fellows, Dr. Kalivani, Dr. Sudha, and so on. And the students, they try to emulate the teachers How do they emulate the teachers? To spread the knowledge about the topics of the different aspects in pediatric nephrology to doctors who, sitting at the comfort of their home, will be able to gain more knowledge so that the treatment becomes rational too, and for early referrals to a higher center when needed. Probably this second IPNA sponsored symposium glomerular disease, I think all the topics have been covered. Today's topic will be from linking to embryology and development. We start from the basics. This is what Professor B.R. says, always be good in your basics and start from your basics so that you'll be able to build it on. So his students also emulate him in this way, starting from the basics, so that if you understand the basics, then you will be able to understand the physiology. Then once the physiology goes wrong, you know the pathology and how it manifests. So it becomes easy, the way in which he starts to analyze every problem. This is how his students also are doing it. I'm really happy to be part of this program. I wish the program a grand success. Kalaivani, hats off to you, and thanks to
Thank you, sir.
IAP Tamil Nadu State Chapter, IAP Chennai City Branch, but not last, but not least, but I think all from Dr. Mehta's. Sameer sir, CEO of Mehta's. The support this program would not have taken place.
Gauri Shankar, sir, your voice is not audible, sir.
Thank you, Dr. Gauri Shankar. Dr. Gauri Shankar? Some connection problem, I think.
Yeah, it's got freezed, sir. You can just take over and proceed.
Thank you, Dr. Gauri Shankar. I just invite Professor Rupesh Reena, the pediatric nephrologist of Akron Children's Hospital, Cleveland Clinic Foundation, to deliver his.
Excuse me, sir. He's just caught up with some emergency work, so he's unable to join, sir.
Okay, I'll invite the next one. I'm happy to invite Dr. Upi Mishra to deliver his talk in the inaugural function. Dr. Upi Mishra.
Dr. Kalaivani, can I have my first slide, please?
Yeah, yes, sir. You're able to view, sir?
Yeah. Good evening to all of you. I express my sincere thanks to the organizers of second IPNA endorsed Webmaster Series 2021 on Symposium of Glomerular Diseases in Children. And on behalf of Indian Society of Pediatric Nephrology and my secretary, Dr. Anil Vasudevan, who is the first speaker in this symposium, I will briefly highlight in 2-3 slides regarding the academic activities of ISPN and its support to this Webmaster Series in the year 2020 and 2021 as well. This ISPN was formed in 2008. Before that, it was named as Indian Pediatric Nephrology Group, a chapter of IAP. Presently, myself is the president, and Professor Anil Vasudevan from St. John's Medical College, Bangalore, is the secretary of the association. Dr. Aditi Sinha is joint secretary, and we have 5 faculty members from different zonal representatives. Various committees are there to supervise the academic activities, research activities, registries, SOPs, website, and other like senior advisory council is there. Academic committee supports this program, fellowship committee, constitutional review committee, bulletin, ISPN bulletin we have launched, website, dynamic website is going to be started soon. ISPN endorsed ISPN support registries and different SOPs for this. Next slide, please. Recently, the ISPN has taken a lead. Previously, we have already published the consensus guidelines in restrained nephrotic syndrome, sensitive nephrotic syndrome. We have revised it. And the consensus guidelines have been published all in Indian Pediatrics, January 2021. SSNS guideline is May 21. And managing children with renal disease during COVID-19 pandemic. This was the first guideline which we published in the first wave in the July 20. United Tract infection guidelines is under preparation. In the April 21, we have circulated e-version of our ISPN bulletin, which shall be published every quarterly. We could not hold the annual conference last year due to this ongoing pandemic. So we organized a digital CME. Host is Professor Anil Vasudevan from St. John's Medical College, Bangalore, 2 days, where 11 lectures and speakers were from abroad as well as from our country. Award paper presentations followed by journal body meeting. And from this platform, last year we started Lifetime Achievement Award, which was conferred to our one of the senior most pediatric nephrology, Dr. B.R. Namarwar sir, Dr. Kumud P. Mehta from Mumbai, and Dr. R.N. Srivastav sir from New Delhi. Regarding ISPN endorsed CMEs, last year, under the chairmanship of Dr. Namalwar, supported by Dr. Kalaivani and Dr. Sudha, they have organized a big success program, IPNA endorsed webmaster series, September to December, and a large number of attendees, about more than 5,000 across 107 countries and 500 plus cities, and individual hospital more than 1,000. And the second one, Neph Kids electrolyte disorders in November 20, where about 370 to 626 participants were there. This was on the entire pediatric nephrology group covered and had a grand success. Next slide. We had collaborated through our central body, Indian Academy of Pediatrics as well, that they have invited us for recording of the lectures on common pediatric renal disorders, and 14 lectures have been recorded and delivered by individual faculty members and our dear pediatric nephrologist colleague. Plus parent education program, another initiative of IAP, where we have formulated the question and answer session in the pharma frequently asked question on nephrotic syndrome, recurrent UTI, congenital anomalies of kidney and urinary tract, that is CACOT, and chronic kidney disease. And lectures on 19th December 20 were also delivered by our pediatric nephrologist colleague on nephrotic syndrome, UTI, antenatal hydronephrosis, evaluation of proteinuria and hematuria, and national pediatric in December 20. These are the certain academic activities, collaborative activities performed by the ISPN during last 1 year. And whole emphasis was given to spread the knowledge of problems related to pediatric nephrological disorder, one. And second, supports the academic program. And my congratulations and best wishes to this second IPNA endorsed webmaster series 2021, where organizing chairman is Dr. Namalwar sir, co-chairperson Dr. Kannan and Dr. Thangavelu, and course director is Dr. Kalaivani, who well deserved this congratulations and working hard day to day and contacted so many persons abroad and across the country for delivery of their talk. And my best wishes on behalf of myself, Secretary Professor Anil Vasudevan, and all the members of ISPN for grand success of this symposium on common glomerular disease in children. Thank you very much for providing this opportunity. to represent the ISPN. And once again, my best wishes to all.
Thank you,
Dr. Kalaivani.
Professor Om Prakash Mishra. Thank you, Professor Om Prakash Mishra.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you. I request Professor Anil Vasudevan, Professor of Pediatric Nephrology from St. John's Medical College, that today's speaker, to offer his felicitations.
Sir, I think on behalf of Dr. Anil sir, also like OP Mishra sir has spoke.
Yeah,
So
okay.
we'll go ahead with
I'll invite then IAP. Can I invite the IAP functionaries? I'll invite Dr. Ismail, President of IAP Tamil Nadu State Chapter, to deliver his felicitations. Dr. Ismail.
Thank you, sir. Am I audible, sir?
Yes, sir. Audible, sir.
Am I audible, sir?
Yes, sir, you're very much audible, sir.
Thank you, Dr. Thangavel, sir. My professor, Dr. Nambalwar, organizing chairman, co-organizing chairmen, Dr. Thangavel, Dr. Kannan, sir, and the course director, Dr. Kalaivani, and my dear friends Gauri and Venkatesh, and all the participants. Good evening to all of you. As IAP president, indeed, we are very happy to be a part of this webinar series on pediatric glomerular disease, and I wish all success for this program. With these few words, I hand over the proceedings back to the course director. Thank you.
Thank you, Dr. Ismail, for your felicitations. I invite Dr. Venkatesh, who is the president of IAP Chennai City branch, to offer his felicitations. Dr.
So good evening
Venkatesh.
to all. Good evening to all, and pranams to my respected teacher, Professor B.R. Namalwar. Chennai City branch is happy to be associated with Pediatric Nephrology Department of Dr. Mehta Hospital in conducting this IPNA Webmaster Series, which will benefit practicing pediatricians and students. My best wishes to the organizing team and Dr. Kalaivani Ganesan, Course Director, for the success of the academic event. Thanking you.
Thank you, Dr. Venkatesh. Thanks for felicitations. May I invite Professor Edwin Fernando, the Professor of Nephrology, Stanley Medical College, and the nephrologist of Mehta Multispecialty Hospitals.
Edwin sir is not there, sir. Like we can proceed with it. Not join, sir.
Can I invite Dr. Saravana Kumar, the unit head of Mehta Multispecialty Hospital, Chetpet, to deliver his felicitations?
So Saravana Kumar sir is also caught up with emergency cases.
I'm very happy to invite Mr. Samir Mehta, who is the success bringing in most of the academic programs because of his encouragement in active research, active academic programs. So I invited Samir Mehta to deliver his felicitations for this program. He's the Vice President or Vice Chairman of Mehta Multispecialty Hospital. Over to Mr. Samir Mehta.
Thanks, Dr. Thangavelu. First of all, I hope all of you, your families are safe. I think this is an unusually rare time because for the teacher of teachers and for the many teachers amongst you, it must pain most folks that you can't assure your customers, your patients are safe at a time like this. And I think that's what we like a lot about this particular community at Dr. Mehta's, that you work with each other, you spread the best practices across institutes, hospitals, across the world and locally across the city. And I think one piece of that goodwill, specifically because Dr. Namalwar is felicitated here, for the very first time we are seeing Child Trust having approached Dr. Mehta's to help them with treating COVID care patients in something we do. Dr. Mehta's now has a name because of the wonderful teachers in pediatrics, in pediatric nephrology, and across different super specialties of pediatrics. But what we forget sometimes is our parentage is also in adults. We started off in the world of maternity and ladies once upon a life and surgical. And to be able to treat over 5,000 to 10,000 customers through COVID is a rare privilege because we can help people save their lives. working together with other pediatric institutions, both locally and globally, to share those best practices and sometimes share the care is what we think this group has helped bring to us in Dr. Mehta's. So I think more than anything, wherever you are in the world, please stay safe. Wherever you are in the world, it's a privilege because you are sharing the time at one of the toughest periods of life to learn from each other and to learn some of the best things about diseases that aren't so common, but perhaps tomorrow we can help cure in a larger, impactful manner. So I think with that, I thank you. I wish you a wonderful program. And actually, I should not take a lot of credit because most of this is taught to us by our grandparents, Dr. Mehta's, both Savita Bain, who was my grandmother and grandfather, but also from some of the younger generation and the newer folks like Pranav, who was very keen on academics and research being in part of Dr. Mehta's. But I think really the person I have to give a lot of credit for is Dr. RSS, Dr. Thangavelu, and Dr. Namalwar, because if they hadn't beaten me up early with a lot of verbal sparring, we would not have appreciated how important the value of academics and research in a hospital that fundamentally looks after care and cure is to help bring the best of the best together. Thank you.
Thank you, Mr. Samir Mehta, for your wishes and prayers. Thanks a lot for this. Now invite Dr. Pranav Mehta, emergency physician, and he is very keen on academic research in addition to patient care in Mehta multi-specialty hospitals. We need your blessings also, Dr. Samir Mehta, Mr. Dilip Mehta, and Samir and Pranav Mehta. Now I invite Dr. Pranav Mehta to deliver his felicitations for this program.
Thank you so much, Dr. Thangavelu. Thank you so much, everyone. I think this year there is a significance to this conference at this time. We have seen over the last year the loss of parents, of friends, and the loss of mentors and people who have kept us grounded this last year, people who have brought us out of our shells, has basically enhanced our isolation beyond the mere physical. I'm so used to taking for granted flying back and forth to Chennai to visit my parents, to visit my friends, to visit my gurus, such as Dr. Thangavelu, visiting my friends and saying hello. And this last year, having lost that, has spun a significant perspective on my life. So the significance of bringing together so many luminaries at this point goes beyond the pursuit of knowledge. I feel that we should use this opportunity to not just enhance our happiness and success, but also to grow and to not take for granted how much we actually sit in the company of friends and colleagues, and to have created a wonderful community such as the community we have at Mehta's, and people that we genuinely admire and respect. So with the heartiest of felicitations, thank you so much and good luck.
Thank you, Pranav. Thank you very much for that. Now I invite Dr. Kalaivani to deliver a vote of thanks. Before she starts a vote of thanks, I just express my feelings. It's not an easy job to organize 38 talks from national and international faculty, organizing in a period twice a week for a span of some 3 months. It is not at all an easy job. I really admire Dr. Kalaivani's organization ability. It's something really great over her patient's care ability, knowledge, skills, and teaching abilities. Really admire. You are half our age group, but still you did a lot of things. I'm very happy that God has kept only 2 kidneys in every human body. Probably Mehta is blessed to have 3 kidneys. Along with your other colleagues, Dr. Sudha and Dr. Suganya and Kalaivani put together, probably you will put the map of Mehta Pediatric Nephrology Department in the world top levels. That is my request. With that request, I asked Dr. Kalevani to deliver a vote of thanks.
Thank you
Dr.
so much,
Kalevani.
sir, for your kind words. Good afternoon, good evening, and good morning to everyone. I deem it as a great honor and privilege to propose the vote of thanks on this memorable occasion. I would like to first of all start my giving glory to the Almighty God for making this occasion a resounding success. First and foremost, I would like to thank the International Pediatric Nephrology Association, IPNA. At the end of every hurdle, we have a big reward awaiting for us. And the same way, this COVID has actually brought us to online platform and made us act innovatively to conduct a series of classes to keep the academics going. And I really thank IPNA for funding the webinar series. I thank our Indian Society of Pediatric Nephrology, ISPN, Indian Academy of Pediatrics for acting as a guiding force in all academic programs. And this series is completely based on practical aspects of glomerular disease and will be delivered by the experts and the topics is covered from basics to the updates. And taking the success story of 2020 series, which was actually first of its kind, and has acted as an inspiration to sketch out this year's scientific program and getting into the core nephrology topics. And I should really admit Dr. Mehta's hospital being one of the best teaching institutes in all academic activities. Last year, the whole series was sponsored by our hospital. And I sincerely thank our chairman, Dr. Dilip Mehta, our vice chairman, Mr. Samir Mehta, our director, Dr. Pranav Mehta, Dr. Kannan, our medical director, Dr. Edwin Fernando, our senior nephrologist, Dr. Saravana Kumar, our unit head, to make this year event possible as well. And I'm really grateful to all senior pediatricians, Dr. R. Shanmugasundaram, Dr. L. Subramaniam, Dr. Nedunjalian, Dr. Annamalai Vijayaraghavan, Dr. Elilarasi, Dr. Prem Kumar for supporting us. And I should tell you that making a dream come true cannot just be achieved by blessings alone. It requires a lot of moral support and guidance. And such support and guidance can be rendered only by a man with goals. And in that way, I can rattle out few people who have really encouraged me to attain my goals. Dr. B.R. Nammalvar, Dr. Thangavelu, and late Dr. M. Vijayakumar. My special thanks to Dr. N.C. Gaurishankar and Dr. Srinivasan sir, who have always been my support in reaching my goals. I also extend my thanks to my own colleagues, Dr. Sudha, Dr. Sukanya, and our fellows, Dr. Pooja, Dr. Sunil. And I also thank our IT department, branding, and medical social worker of Dr. Mehta's hospital for extending their support in all possible ways. My special thanks to Mr. Joshua for his excellent coordination. Last but not the least, I thank all my family members and my kids who have always been my pillar of support. If we take the strength of any scientific program is having the best of faculty, and as Dr. Thangavelu sir rightly pointed out, we are proud to have them all together for you to share their knowledge. And my real thanks to all national and international faculties for their contribution. I have always realized children can actually fall sick very quickly, but with good care and they can recover fast and completely. And such sick children transform into healthier kids as a result of good care. And I'm pretty sure at this end of series, you will be offering the best of care to your patients. And all talks in our series are clinically oriented discussions, which will actually enable us to manage patients better in our day-to-day practice. So without wasting much time, let's move on to the scientific program to hear from our expert. And today's talk is by Dr. Anil Vasudevan. Dr. Anil Vasudevan is a professor and head of Department of Pediatric Nephrology, St. John's Medical College Hospital, Bangalore, and his area of interest is genetics of renal disease. He's also keen in molecular basis of nephrotic syndrome, acute kidney injury, and low-cost devices. He is a current ISPN secretary, and he's member of committee for competence-based syllabus in pediatric nephrology. And he is a member of PhD committee of JIPMA, and he is a member of editorial boards, and he has got a lot of national and international publications to add on to his CV. I welcome Dr. Anil Vasudevan to deliver his talk on glomerular disease linking to embryology and development. Over to Dr. Anil Vasudevan.
Good evening, all. Am I audible, Dr. Kalavan?
Yes, sir, you're audible, sir.
Thank you. Good evening, all. I would like to thank, before I begin, the Pediatric Symposium on Glomerular Diseases, the organizing committee led by Professor B.R. Namalwar, sir, Thangavelu, sir, and Dr. Kalavani. It's a wonderful thematic symposium that has been designed. So, is there any way, Dr. Kalavani, I can use a pointer? I mean, I'm not able to, because there are a lot of images.
No, sir, I don't think it is accessible to use a pointer, sir.
Okay, because there are a lot of images, and I'm not sure whether, the points that I will be discussing will be highlighted. Can I get a control of the, is it possible? Or?
I'll just check on, sir, 1 second, sir.
It's okay, otherwise it's okay. I mean, I hope the messages are clear. And because I'm now getting some internet signal weakness, I will be switching off the video during the talk so that the session goes uninterrupted. So as we all know, the glomerular diseases in both children and adult is actually a basket of various conditions that affect the glomerulus. And over the next 35 to 40 minutes, I'll be briefly reflecting on the insights into the embryology and development of the glomerulus and its contribution to the glomerular disorders. So there are roughly around 18 subtypes of glomerular diseases. I mean, there is no standard classification, but based on the data that is available, there are around 18, and of these, around 8 to 10 of the glomerular disease are very common in both adults and children. So the graph that I'm showing is the data from the renal biopsy performed in the UNC, that is University of North Carolina Chapel Hill Center, over the last 30 years, up to 2015, that included around 21,000 adult and children, of which 2,000 were children. And as you can see here, sorry, the slides are not. As you can see here, in the children, FSGS, IgA nephropathy, MPGN, lupus stand out, while in adult, it is the diabetic nephropathy that stands out as one of the most common glomerular disorder, apart from FSGS. And surprisingly, what is not included in this series is HUS, post-infectious glomerular nephritis. Maybe they're not categorized as glomerular disorder in their series, and also maybe the PIGN is not as commonly seen in their center, reflecting the variability in the presentation across the continent. And not only glomerular disease is one of the most common diseases in children, it also contributes to significant morbidity and mortality. As you can see here, in the etiology of ESRD in children from the USRDS database, the primary and the secondary glomerular nephritis forms a significant chunk of children who reach ESRD. So now when we talk of glomerular diseases, we obviously talk of the glomerulus, and which is inarguably one of the most unique and fascinating vascular structures in the body. It is a unique bundle of capillaries and has 4 intrinsic cells: the visceral epithelial or the podocytes, the parietal epithelial cells, the mesenchymal cells, and the endothelial cells that line the capillaries. Besides, we also need to be aware of 2 regions of the glomerulus, that is the vascular pole and the urinary pole. And I will come to that, the relevance of those poles, when I'm discussing the response of the glomerulus to various injurious stimuli. When we look at the glomerular disease, it can affect any of the components of the glomerulus. For example, like in FSGS, minimal chain disease, membranous, it affects the podocyte. In HUS, it affects the endothelial cell of the glomerulus. In the Alport syndrome, In the Alport syndrome and in anti-GBM disease, it is the glomerular basement membrane that is affected. And then in IgA nephropathy, it's the mesangial cells that are affected. But however, the clinical manifestations of these glomerular diseases are variable in severity, but they are very relatively limited in nature. As you can see here, there are few syndromes that you can fit in all these glomerular diseases with cardinal manifestation of either hematuria or proteinuria. And this is because no matter which cell is affected in the glomerular disease, finally, it is reflected in the effect on the glomerular filtration barrier, where all these cells seem to converge. So this glomerular filtration barrier is formed by the endothelial cell, the glomerular basement membrane, and the podocyte or the visceral epithelial cells. And as we all are aware, in a clinical practice, we use a syndromic approach initially to understand the underlying glomerular disease. And this, combining it with the histological features, has been the bedrock of the nomenclature of the glomerular diseases. While there is a lot of information and knowledge about the inherited glomerular diseases, but far less is known about the mechanism that contribute to the proteinuria and hematuria in acquired kidney disease, for example, in IgA nephropathy, or in the other forms of acquired, like lupus nephritis. So whatever we have got insights on the embryology and development of the glomerulus is because of immense work done by the researchers using various tools that includes cultured cells, growing the kidney-like organs in a petri dish, using animal models like inducible transgenic mouse lines like the TH1.1 model. And the data that is generated from these experiments is analyzed using high throughput techniques like transcriptomics and omics, that includes proteomics and genomics, and also using advanced technology to capture the images of the developing glomerulus using various tools like, for example, multiphoton imaging. So the combination of these tools has now helped us understand the development of the glomerulus. And this is a snapshot that I have provided, and it's a very complicated process, but I will just highlight the key aspects of the development of aspects of the glomerulus. And I should mention that many fundamental questions still exist regarding the normal glomerular development and maintenance. So as we all know, kidney develops from two structures, the ureteric blood and the metanephric mesenchyme. The histopathological staining and the red arrow points towards the metanephric mesenchyme. The condensed mesenchyme proceeds through several well-defined stages in embryonic development. And this glomerular morphogenesis can be categorized as the renal vesicle stage, then the comma, the S-shaped capillary loop, and the maturing stage. The aggregates of metanephric mesenchyme first form a polarized renal vesicle, and the cells begin by assembling the basement membrane in the vesicle. And I mean, I don't have the picture of the renal vesicle, and then this vesicle generate to form the structure known as the comma-shaped body. In the comma-shaped body, I mean, this is an electron microscopy. Unfortunately, I don't have a pointer. You can see the early cells of podocyte, and then there's a cleft that results in a comma-shaped. And this formation of cleft is followed by a formation of a second cleft that results in a S-shaped body. So the glomerular development is first visible in this S-shaped body, when the precursor cells at the most proximal end begin to express proteins that are specific for podocyte cell. That is highlighted in the pink color and as mentioned as PO. Then distinct cell types are appear after this appearance of the podocytes. It is into this cleft that the vascular endothelial cells migrate, followed by the mesangial cells. And you can see in the immunofluorescent microscopy, the red are the podocyte and the green stainings are the mesangial cells. Once inside the developing glomerulus, the endothelial cells proliferate in situ and aggregate to form the first capillary loops in the so-called capillary loop stage. But an important developmental process in this phase is that after initial influx of the endothelial cells, mesangial cells enter the glomerulus, forming a stalk or the core of cells around the early single capillary loop. The subsequent looping of the glomerular capillaries, as you can see in the maturing stage, will not proceed in the absence of mesangial cells, or if the glomeruli has defects in the basement membrane that prevents the adherence of mesangial cells. So mesangial cells have an important role to play in the development of the capillary loops. And finally, once all this is set, this development occurs repeatedly in an iterative process until the full endowment of nephrons have developed. So as you can see, this whole process of converting the metanephric mesenchyme into a mature glomerulus it goes through a series of stages, and this is orchestrated and regulated by many molecules, many of which are known, some of which they are not very clear. But in this slide, I want to highlight two key aspects. One is that the metanephric mesenchymal cells undergo a decisive fate specification into what is called as a FOXT1 positive cells, and the other is called as a 6-2 positive progenitors. And there are basically two gene products that are mainly involved in the process of metanephrin differentiation. That is the PAX2 and the Wnt4. The FOX1 deep1 positive cells will give rise to several different types of cells, such as the mesangial cells and the angioblast, while the 6-2 positive cells give rise to all the epithelial cell type, that is the visceral and the parietal epithelial cells. And the second thing I want to highlight is that the critical phase of converting a stromal mesenchymal cell into an epithelial cell is known as the mesenchymal to epithelial transition, is regulated by a lot of molecules at the various stages. Like as you can see here, the 6-2, the PAX, LH11, Wnt4, Notch, and E-cadherin. And any disturbance in this regulation can result in impaired development of the glomerulus. And also in the mature glomerulus, any injurious stimulus can activate one of these molecules, which can result in converting the epithelial back into a mesenchymal. And that's one of the processes of glomerular injury. So I will now come to the individual cells quickly. And I will start with one of the least discussed cells, and that is the mesangial cells, which plays a very important role in the glomerular homeostasis, and it should not be overlooked. The origin of mesangial cells remains a mystery, but it is argued that it comes mostly from the metanephric mesenchyme, but a small proportion also comes from the hematopoietic progenitors. These cells constitute actually 30 to 40% of the total glomerular cell population. So as you can see, it contributes a significant composition of the glomerulus. Mesangial cells and the matrix form the mesangium, and they form the central stalk of the glomerulus. And they closely interact with the endothelial cells and the podocytes. The mesangial cells are separated by intercellular spaces containing extracellular matrix called the mesangial matrix, and this has a different composition from the globular basement membrane. Although they contain type 4 collagen, the type of chains are different. They also contain type 5, laminin A, B1 and B2, and considerable amount of fibronectin, and then sulfate proteoglycans, enactin, and nidogen. And they all form, some of these form the anchoring filament from the mesangial cell to the glomerular basement membrane. One of the key factors that regulate the mesangial cell development is the platelet-derived growth factor B, which is a key chemotactic factor that directs these cells into the glomerulus from the metanephric mesenchyme. So these mesangial cells have multiple functions, right from beginning, providing the structural support, right from providing the structural support to to generating the extracellular matrix, and it has contractile elements, so it helps in regulating the capillary flow and the ultrafiltration surface area, and also helps in moving the trapped residue that is aggregated in the and prevents the clogging of the glomerular basement membrane. So as you can see here in this cartoon, the mesangial cells plays a critical role. As you can see, it is in communication with all the other intrinsic cells, whether it's the podocytes, whether it's the endothelial cells or the basement membrane. And as you can see in the other column next to it, it is either secreting a lot of factors or receives a lot of signaling through various factors by the various receptors. The development of the mesangium depends on a healthy podocyte, because the transcription factors secreted by podocyte helps in maturation of the mesangial cells. For example, you can see here in this diagram, POD1 and FOXT2 are two transcription factors secreted from the podocyte. And when these are knocked out, you can see that the mesangiums are poorly developed, and this in turn leads to the poor development of the glomerulus. In addition, there are 3 to 10% cells of the within the mesangium that have a different phenotype. That is, they exhibit phagocytic properties and express surface elements of cytokines that are normally produced by immune cells. And this results in participation of these cells in glomerular inflammation that we see in many of the glomerular diseases. And this happens because they are equipped with a set of innate pathogen recognition receptors that allow them to recognize a number of PAMs and DAMs and to translate the recognition of the dangerous signals into secretion of pro-inflammatory mediators like the cytokines and chemokines. So what happens in glomerular diseases? As you can see, they're subject to various injury mechanisms, including from immune complexes, abnormal digestion, IgA, oxidative stress, and in diabetes, they're exposed to advanced glycation end products. And they respond by either proliferation or by producing increased cytokine, or by just not only proliferation, but also increased formation of extracellular matrix and also reorganization of the extracellular matrix. And depending on which of these responses happen, the final pathway will be either hypercellularity or sclerosis. So as you can see here, once the mesangium is exposed to an injurious stimulus, it has 2 pathways to take. One is mesangiolysis. And one of the common conditions where we see mesangiolysis is in hemolytic uremic syndrome. But in other glomerular diseases, it's rarely spotted on renal biopsies, probably because only persistent strong complement activation creates this lesion, while transient mesangiolysis is rapidly replaced by the remaining surviving mesangial cells by a proliferative responses. So, and if that response happens correctly, it results in a normal glomerulus. If that proliferative response is inadequate, then it results to what is known as a hypercellularity sclerosis. On the other hand, the mesangium can get activated and goes into what is called a non-reconstitutive proliferative pathway. And if and as you can see, like in PIG, and there is some mesangial hypercellularization, which actually reflects a reparative process. And then those mesangial hypercellular proliferation get arrested at a particular time point, and apoptosis of this cell happens, thereby restoring to the normal glomerulus. But when this restoration of the cell hyperproliferation does not happen and remains unchecked, this results in not only increased mesangial cells, but also formation of increased mesangial matrix, and that finally leads to sclerosis. And there are many factors that are involved in this process, and it not only affects the glomerulus, but the factors like, for example, TGF-beta, TNF-alpha, and the chemokine that are secreted also induce the interstitium, resulting in interstitial fibrosis. So as you can see here, mesangium not only plays an important role in maintaining the glomerular homeostasis, but also has an important role in the reparative process, as well as in the progression of the various glomerular diseases. Coming to the next cell, it is the glomerular endothelial cells. Again, here, like the mesangial cells, the origin of endothelial cells are fairly is a little controversial, but it is assumed that they come from the metanephric mesenchyme or the hematopoietic progenitors. It's a very unique cell in the form that there are a lot of fenestrations, as you can see in the electron microscopic picture, and these are ovoid and are roughly 60 to 70 nanometer in diameter. And the maturation of the endothelial cells parallels the maturation of the podocyte foot process. So that's all this happens during the S phase and the capillary loop stage. And another unique aspect of the endothelial of these endothelial cells lining the capillary, unlike the other capillary systems like in pancreas or liver, that it is covered by a thin layer of what is called as a glycocalyx, which contains negatively charged glycoproteins, aminoglycosides, and also other anionic particles. And this is supposed to contribute to the filtration barrier. And this endothelial cells are vulnerable to injury by complements, as we see in atypical hemolytic uremic syndrome and also in vasculitis. So one of the key factors, there are a lot of factors that are important for the vessel development and for the capillary formation, including angiopoietin and some substances called T. But one of the most important is the vascular endothelial growth factor that is secreted by the podocyte, and also the platelet-derived growth factor, which is secreted by the mesangial cells. So this is a diagram that shows what happens and how VGF plays a role in the fenestration formation. That is, once it docks into the receptor, it activates the small protein GTPases and results in the actin rearrangement, forming fenestral cytoskeletal ring. And then it also recruits what is something called as PV1, that is plasma vesicle associated protein, that results in the forming of the fenestration. Now, the importance of VGF can be understood from this electron microscopy and immunofluorescence diagram. So when the VGF is knocked out, in the normal, you can see here the endothelial cells are formed. But when the podocytes are knocked out, you can see that the endothelial cells hardly develop. As you can see, there is the red signal is missing in the image to the right of that, and it is called as a ghost capillary. So the podocyte play an important role in the development of the endothelial cells. Similarly, the mesangial cells also play an important role in the development of the capillary. As you can see here, the platelet-derived growth factor that is secreted helps in the division of the capillary loop, something called as an intussusceptive angiogenesis. And absence of PDGFR results in formation of only a single capillary loop and dysfunction of the glomerulus. So as you can see here, the development of the mesangium and the endothelial cells are closely linked to each other, and disturbance in various molecules that are involved in the development results in various glomerular disorders. For example, the WT1, we know that it's a podocyte-specific protein, but when you see a biopsy, there is a diffuse mesangial sclerosis. And I've just given an example how podocyte regulates the mesangial and the endothelial development, and you actually don't see any capillaries in these biopsies, and this is one of the mechanism. Similarly, LAMP2, which is actually a glomerular basement membrane protein, also results in a similar picture, and where there is absence of capillaries, and this happens because mesangium is unable to adhere to the glomerular basement membrane, and we know that mesangium through the PDGFR receptor is important in the formation of the capillary loop. So there is a lot of crosstalk that happens during the glomerular developmental process. Now, coming to one of the what was considered as a very benign cell, except in few glomerular disease, that is the glomerular parietal epithelial cells, which is considered to be like bystanders and victims of the glomerular disease process, and is no longer considered as merely lining the cells. The developmental origin of these cells are same as that of podocytes, and during the S-shaped stage formation, these two podocytes have different fate and also express different kind of proteins, and that brings their unique characters to each other. What is now known is that these cells have the capacity to proliferate under physiological conditions, and that different subpopulation of these parietal epithelial cells exist both in healthy and the diseased kidneys. Kidneys, for example, and these are known as activated parietal epithelial cell or the podocyte committed progenitor or peripolar cells. And hence, the view that it is just a mere cells lining cell is changed to the parietal epithelial cell being viewed as a potentially harmful or helpful in glomerular diseases. So how does that happen? So that happens because many of these parietal cells are actually progenitor cells that are located at the urinary pole of the glomerulus. And these are regulated by a lot of molecular factors like Notch pathway, the retinoic acid pathway, the interferon pathway, and the DACH pathway. And you need a synchrony between these molecular players to ensure that the glomerular progenitor cells does what it is required. That is to repair or replace the injured podocyte in various glomerular diseases. If there is a dysregulation of these molecular players, it results in different phenotypes, as we'll see in the next slide. So what happens is that when it suffers an injurious stimuli, there is increased albumin endocytosis because of leakiness of the glomerular basement membrane. That binds to retinoic acid. And then what happens is further activation of the parietal epithelial cell is stopped. Instead of that, it takes either the apoptotic pathway or there is a reduction in the tight junction proteins, which results in further increased permeability of this glomerular basement membrane. And this leads to crescent formation or periglomerular inflammation. On the other hand, the activated PEC, if all the molecular signaling is correct, leads to regeneration of the podocyte. But if this molecular signaling is incorrect, it can either lead to unchecked proliferation, as seen in crescentic glomerular nephritis, or pseudocrescent formation, as seen in collapsing glomerulopathy, or it can lead to just production of increased extracellular matrix, and that which leads to glomerular sclerosis. And a lot of animal studies in rat have identified various players that are associated with this various phenotype. And the images that I'm showing are the extracapillary proliferative lesions consisting of the parietal epithelial cells. The one is the Fsgs, the other one is the crescentric. And these are double immunostaining for Claudin-1 protein that are expressed specifically in parietal epithelial cell. That is the green arrowhead. And the red arrowhead points to the specific heparin sulfate that are seen in the extracellular matrix. What you can note in these two images are the marked hyperplasia of the Claudin-1 positive cells in both Fsgs and the crescentric glomerulonephritis. The more cellular is the Fsgs lesions, more likely are to find these CD44 positive cells. So it is not just in crescentric glomerulonephritis, but also in other glomerular diseases like Fsgs, even membranous. They have found that anything where there are increased cellular elements, it's more likely to constitute of these activated parietal epithelial cells. Now coming to the star of the glomerulus, that's the podocyte. And it is not surprising that it's considered as a star because the great deal of excitement and emphasis that has been generated through a lot of work which has really mapped the structure of the podocyte and its function to a large extent. It is considered as the key to the maintaining of the filtration barrier. And as you can see, this one is the basal view, the other one is a luminal view. It consists of three parts: the body part, the major processes, and the foot processes. And the foot processes interdigate to form what is called the slit diaphragm. So the glomerular development happens from the S-loop stage and continues into the capillary loop stage. These are actually tall columnar epithelial cells. And then as they progress through these various stages, they become shorter and broader. And also they start developing these foot processes. The other thing to observe is that the tight cell adhesion complexes that are apical move into the basal, which allows them to form the foot processes. And this is an electron microscopic view, a cross-sectional view of these foot processes. So with the discovery of nephrin gene as a cause of congenital nephrotic syndrome, over years, more than 80 genes have been identified that are responsible to maintain the glomerular slit diaphragm. And you can see here, it includes structural proteins, it includes nuclear proteins, it includes mitochondrial proteins, and includes lysosomal proteins. So all kind of proteins have now been identified that plays an important role in podocyte, and which in turn helps in maintaining the integrity of the glomerular filtration. Filtration barrier. So it is not only the inherited diseases that affect the podocyte, even acquired diseases can affect the podocyte. As you can see here, there's a spectrum of diseases that results in podocyte injury, right from the genetic causes to the acquired causes like immunotactoid in adult, hypertension, diabetes, and also aging. So this interaction between the environment and the genetics is now being better understood, and I hope while discussing this nephrotic syndrome, a lot of further information will be given. So one of the hallmark of podocyte injury is effacement. As you can see from the electron microscopic picture, these foot process efface, and you can see the exposing the capillary surface. But it is just the start of the podocyte injury. The fate of the podocyte cells can vary based on the injury stimulus. So it can range from just effacement, as is in minimal chain disease, to podocyte detachment and cell death, resulting in segmental sclerosis. Or it could be that podocyte itself is not formed during the developmental stage, what is called the developmental arrest. This results in mesangial sclerosis. Or in some of the conditions like collapsing HIV nephropathy, there's dedifferentiation of the podocyte, and then it enters back into the basal cell state and then proliferate, resulting in actually increased podocyte number, and that is called as the collapsing glomerulopathy. Although this injury happens, what happens later depends on the glomerular epithelial stem cells or the activated parietal epithelial cells. So as you can see here, once there is a podocyte injury and detachment and loss, the cells located in the urinary pole, I'm sorry, I'm not able to show you with an arrow. The cells located in the urinary pole migrate into the vascular pole and replace this podocyte. They form some kind of a bridge, as you can see in this picture. So that is how they replace the injured or the damaged podocyte. But when the injury is severe and massive, this may not be enough to compensate for the regeneration of the podocyte. And that's when there is instead of having increased number of podocyte cells, there is actually deposition of a large amount of extracellular matrix that leads to glomerular sclerosis. Wiggins et al. Has found that if the podocyte number damaging is less than 20%, they can be repaired. If it is between 20 and 40% of podocyte loss, it leads to a scarring response. And if there are more than 60% of podocyte loss, it leads to globally sclerotic glomerulus, and which is actually non-filtering. The last fate of an injured podocyte is the dysregulation of these epithelial stem cells that create their own lesions. So as seen in crescentric and collapsing glomerulonephritis, where there is unregulated proliferation of these cells. But these proliferated cells are not mature, are dysfunctional, and this results in further damage to the glomerulus. Understanding how the self-renewal and fate decisions of the glomerular epithelial stem cells are perturbed or modulated is not very clear. And it will be of crucial importance to know this, because this could help us to discover novel tools for prevention and treatment of glomerular sclerosis. So when I've finished talking about the individual cells, there is not a cell, but the basement membrane, which also plays an important role in maintaining the integrity of the glomerulus. It is formed by the podocyte and the endothelial cells. it's usually thick as compared to basement membrane of other cells. The main components are the laminin, the collagen alpha 3, alpha 4, 5, the heparin sulfate, proteoglycans, and adenine. What is very important, I'm just focusing on two aspects. One, that the laminin is the one that is required for the normal development of this basement membrane. As you can see here, the knockout of this protein leads to a poorly developed glomerulus. And hence, this presence of this protein is very important in maintaining the JBM integrity. But the most common disease that we hear that we see is the Alport syndrome, where there's mutation in this collagen alpha 3, alpha 4, alpha 5. They're not important in the development of the filtration barrier, but subsequently it leads to damage because the mesangial cells cannot adhere. It leads to a lot of molecular signaling that affects the podocyte and the mesangial cells. So, and also this alpha 3 chain are the major source of the autoantigen that we see in good pasture glomerular nephritis. An interesting disease that we see is the nail patella syndrome. Now, nail patella syndrome, the protein involved is LMX1B, which actually is not a part of the glomerular basement membrane. But when you see a biopsy, there is a lot of mesangial sclerosis abnormality of the glomerular basement membrane. And that is because these proteins regulate the expression of alpha 3, 4 and alpha 4 collagen. Again, as we see, there is a lot of crosstalk that is happening during the glomerular development. And hence, this crosstalk is very important to maintain the glomerulus. So with the discovery of a lot of podocyte genes and structures, there was a very podocentric view of this entire glomerulus, and that being the critical cells. But then later on, there's a growing realization that no single layer of the glomerular capillary can by itself represent the primary barrier. And this was something referred to as dynamic reciprocity between the various intrinsic cells of the glomerulus. And the exciting era of looking at this started with the discovery by Suzanne Kuegen's group of the VEGF production by the podocyte and its essential role in the adjacent endothelial cell function and survival. So as we can see here, the mesangial cells can affect the podocyte. It can also affect the endothelial cells by a number of signaling molecules such as midkine, transforming factors, and nitric oxide. Similarly, endothelial cells can produce a number of growth hormones such as epidermal factors, insulin-like and hepatocyte factors that can affect both the mesangial and the podocyte. So from a podocentric view, we are now moving towards a concept of viewing this glomerular filtration barrier or the glomerulus as an integrative glomerular barrier complex where all the cells play an equally important role in maintaining its normal function and structure. So in summary, glomerulus is a specialized capillary structure with a continuous quilt of communicating cellular and extracellular elements. These cells, either be it mesangial, endothelial, or the podocyte, do not develop in islands, but in fact, they're regulated by a complex and a dynamic signaling machinery and also influenced by the development of the other cells. And while we have more information about some of the key pathways involved in the glomerular development, what is not very clear is the precise crosstalk that happens between these resident cells of the glomerulus. And it's important because elucidating these signaling pathways and crosstalk can help us to actually potentially identify druggable targets which may be used for treatment of proteinuria kidney diseases. Thank you.
Thank you so much, sir. It was really a great talk by Dr. Anil Vasudevan, taking us into the molecular level of nephrology. Many of the molecules, in fact, we have never heard of it. It is the first time we are hearing as well. Thank you so much, sir. I think we don't have much questions. We don't have questions pertinent to the subject.
I know. So generally, the development and the embryology are usually a dry topic. So I try to enliven by colorful pictures.
True, sir. It was really made interesting by you, but probably it is to the depth and it is core nephrology. So we do not we don't have much questions on it, but it was an excellent talk, sir. Thank you so much, sir.
Thank you. Thank you for your invite.
Thangavelu sir, do you have anything to share, sir? Thangavelu sir? I think sir is not heard. We just have few instructions for the participants. We have got, we will be having the polling sessions, and the dates of the polling sessions will be intimated shortly, probably in the next webinar on Wednesday. So I request the participants to actually enter their right mail IDs and contact numbers for easy communication. There are no questions. I think we'll end this session if there are no questions. I think we have got few questions, sir. Anil sir, you're there around?
Yeah, I'm there.
There are few comments. And the question is, can LMX1B mutation produce FSGS without other features of nail patella syndrome? If the report says mutation of LMX1B gene zygosity heterozygous, but the mutation is variant of uncertain significance. It's a question from...
It's more of a clinical question, but LMX1B does cause various type of presentations, and many of the time proteinuria is the predominant manifestation. So it's only upon genetic testing when these patients are either steroid resistant or on examination you find a hypoplastic patella, you subject them to a genetic testing. And only then when we do a reverse, what is called a reverse phenotyping, look at the eyes where we find glaucoma. So because proteinuria is the only syndromic manifestation, it may appear that it's coming as an isolated, but a closer examination may reveal other abnormalities. And this variant of unknown significance is related to the variant, and usually they are novel, and there are no functional evidence that this variant can cause the damage. Hence, they are classified as VUS.
Okay. That answers Dr. Kanika's question. And the next question is, which molecule do you think will be clinical targets in the future?
It depends on what glomerular disease we are talking about. So there are a lot of molecules that are in the pipeline and which has been promising, like roscovitin in podocytopathy, and then TGF beta inhibitor factors, and then a lot of these stem cell related molecules. But one complexity of the glomerular development is that it is not that these factors work in isolation. So it's like an orchestra or a symphony. And these players come in at different time points. They play the role, go back, again come back. So the timing is very important when we are administering these molecules. And also, this may be one of the reasons why, although a lot of molecules have shown to be effective in vivo or animal studies, have never come into the clinical. But we hope that mapping these pathways using single-cell RNA technique, like as done with IgA nephropathy, with diabetic nephropathy, I think a lot of molecules that were identified for diabetes came up from these through experimental strategies. We hope that similar thing also comes for other glomerular diseases.
Kalaivani, can I have a question?
Yeah, sure, sir.
Yeah. It's just a simple layman question.
Yes.
See, like as in neurology, many diagnoses have been made with the blood investigation during genetic studies, which has almost replaced the other investigation like EMG and muscle biopsy. Will it happen to nephrology investigation also, or still you have to do renal biopsy and then to go for genetic studies?
A good question, sir. I mean, the liquid biopsy versus a solid biopsy, that was we call this. So each have its own role. For example, we have stopped now doing biopsies in congenital nephrotic syndrome. We entirely depend on the genetic testing, and if genetic testing shows a pathogenic variant, we no longer do a biopsy unless in some definitive conditions. But in the other hand, a lot of the time, genetic diagnosis comes as variant of unknown significance. It becomes important to do a biopsy to understand what is exactly happening. Second is that although we have a genetic diagnosis, but in very few conditions like ADPKD or in Alport, there is a genotype-phenotype correlation. So we can predict whether this patient is going to go into renal failure quicker or not. And in these set of conditions, we might require to do a biopsy for prognostication. But I agree with you, sir, that in inherited conditions, like in HUS, congenital nephrotic syndrome, genetic testing is the first choice rather than a biopsy.
Thank you, sir.
Thank you so much, sir. Then next question is, can FSGS and MCN present with hematuria?
Of course, I mean, so the hematuria is related to the disruption of the glomerular membrane. And we know that microscopic hematuria is fairly reported in almost 20% of those minimal change disease. What is unusual is gross hematuria. So the hematuria reflects the severity of injury. And it represents persistent gross hematuria is an atypical feature of nephrotic syndrome. And we have seen that FSGS could be an underlying etiology. So as you can see in the first paradigm that I've shown, there may be a considerable overlap between hematuria and proteinuria.
Okay, so and the next question is, are mesenchymal cells pericytes or pericytes in the interstitium too?
Sorry, pericytes are a different type of cells. I mean, I have not brought them here because in the glomerular diseases, they do not play a role. But in renin-mediated and other erythropoietin-related, they do play a role. But they are in the mesangium.
But okay, and not in the interstitium.
Considered as a, they are not. I'm sorry. Yeah, in the interstitium of the pericapillary area, they are not mesangial cells.
Not in mesangial. Okay, and the next question is there any research on stem cell therapy for glomerular sclerosis?
So as I pointed out, the response to especially the podocyte injury is through, initially the podocytes were considered as terminally differentiated cells, like the neurons. And now even neurons are considered that there are progenitors present in these mature kidneys that has the capacity, if given an appropriate stimulus, to develop into a neopodocyte. So, so again, the research work is focusing on how to, jumpstart this conversion of these progenitors into podocyte in this glomerular injury. But as of now, stem cell therapy has been tried in various other diseases, but has not so far been done in glomerular diseases that I'm aware of.
Okay. We have one more question, sir. Does the crescents originate from parietal cells, if Bowman's capsule or visceral cells, or both?
So there was a lot of controversy on what constitutes these crescents. So initially it was considered as a three-cell structure, that is the macrophages and the other immune cells and the parietal epithelial cells. Now with what is called a genetic cell lineage tracing, it is clearly shown that the bulk of the crescent consists of these parietal epithelial cells. But the stimulus for this comes from the of this activation and unregulated proliferation comes from the fibrinogen that comes because of the disruption of the glomerular basement membrane. So same cell is also present in FSGS in membranous. Actually, the stainings of high resolution staining have shown that these cells are present also in other non-precentric conditions like thick lesion of FSGS, the collapsing glomerular nephropathy that you see in HIV and idiopathic.
And we have one more question. IgA nephropathy and HSP nephritis still considered ends of a spectrum?
So I mean, so I will leave that question to the session on IgA and HSP. Of course, I mean there are they are now termed as the IgA or the vasculitis, but the predominant stimulus of injury happens from the deposition of these abnormal IgA cells in the mesangium, and now you have a multi-hit hypothesis theory that explains the pathophysiology in IgA nephropathy, and histopathology has shown differences between the HSP and IgA, but why that happens is not very clear.
Okay, Dr. Kalimani, if there are no more questions, can I invite Professor Edwin Fernando, Professor
Yes,
of
sir, we are done with
Nephrology,
the
Stanley
questions.
Medical College, and a nephrologist of Mehta Multispecialty Hospital, to offer his comment about the subject. Of course, all the pediatric specialties are developed from the adult only, except NICU probably. Either PICU or nephrology or hematology, all of them has originated first from the adult department, has been the pediatric department learned from that. I request Professor Edwin Fernando to offer his comment on the subject. Is Edwin is available, Kalivani?
I think sir has joined through as a participant, not in the list of names as host. He's not there in the list of names of hosts, sir.
Okay.
We'll just check out if there are few more questions, sir. In case if you don't have any questions, we'll just close the session, sir. 1 second, sir. I'll just check out.
Anil, was really great of you. This itself is something really, you're coping along with all the very happy that Indian pediatric nephrologists are coping along with the development happened in worldwide. You're no way less than that. Despite all the shortcomings we have, something really great of you to present a very deep insight into the genetic aspect of renal diseases.
Thank you, sir.
Thank you very much.
Thank you for your.
I think it's the right topic as a first topic. We believe that when we are born, that's what our ancestors believed. When we are born, everything is written there.
Right. I think, the answers lies in those developmental biology aspects for many of, even for the acquired diseases.
Okay. Thank you, sir.
Thank you so much, sir. It was an excellent session. As Dr. Thangavelu, sir, rightly pointed out, you took us in and out of molecular levels of nephrology. So it was really interesting. I think the topic was aptly given to you because no one else would have done justice to this topic other than you, sir. Thank you so much, sir.
Thank you.
Thank you, sir.
And take care.
Thank you, Thangavelu, sir. You have any other comments to add, sir?
Thank you.
Thank you, sir.